When I met with the director of our IT department to try and flesh out our strategy for medical information, and provided him with what I considered to be a wish list, he then suggested that in fact there was more functionality in the package that we already had, namely PAS, that we hadn't utilised. However, when we first looked at it, my impression was that it was way more than we needed, and if we were to hit our clinicians with all of that in one go, that we might get pushback. And of course, it's always the challenge for IT is to avoid giving us too much. So my goal in all of this has been to say, keep it simple. Let's choose exactly what we want and no more. Let's make it really robust, reliable, clear. Let's remove all the extraneous interface. I've seen some horrible electronic medical record interfaces that with masses of drop-down boxes and nested menus, which is just going to be instant pushback from our doctors. So in a way, I guess I was inspired by the whole ethos of Apple, which is apparent in their iPad, which is to make the complex look simple and to remove the clutter. And when we started doing this, and iSoft started giving us some trial versions of this, a lot of extraneous information started to come through, and a lot of information that they thought would be interesting to us. So my role in this was to say what we didn't need and to advise on the interface to make it as clear as possible, to make sure that results came through reading from left to right in chronological order, that abnormal results were highlighted, that a lot of the metadata that accompanies our results was either stripped out or parked down out of sight at the bottom of the screen, so that it looked like, looks like an Apple product. And I think that's what we've achieved so far, and what we have to keep working on is making it simple. And I just like a big button that just says View Image. I like a button that says Clinical Results, and there they are, they just pop up. It's taken no time to learn this. And I always think the hallmark of good software is when you never have to read the manual. I don't think anybody's ever read the manual on an iPad or an iPod, and yet we all remember those huge Microsoft manuals. And it's been the same with this. Our IT department, together with iSoft, did produce a user manual, which I have yet to look at, which I consider to be a positive. So initially what we chose to do was just to give the doctors the key information, the images, the radiology results, the laboratory medicine results. And in many ways, I think this is going to cover 80% of the requirements. But as soon as we introduced this, and I showed it to some of our senior doctors, immediately hands started going up, indicating other things they want, which I think is fantastic, because hopefully we're in a position to meet those needs. So other suggestions that we've taken on board and we'll be looking at are ECGs, which links in very nicely with the fact that we've committed to an acute STEMI project with Ambulance Victoria, and I think we've now seen that as a priority to get ECGs into the hands of our interventional cardiologists. CTGs for the obstetricians was an immediate request, and echocardiograms from the cardiologists. So I think this is one of the important things, is to keep going back and forth to the clinicians and making sure that we're giving them what they want and that the next developments are what they want and what they need. So other visions for it in the future are to link it into electronic ordering of tests. If you can pull up the full blood count and you plan to give a couple of units of blood, you'll want to see what the hemoglobin is tomorrow morning. So we envisage being able to just click on FBE tomorrow morning, and without having to go back to the nurse's station, without having to be in the hospital, know that a test will be done the following morning and will be available when they come to do their morning ward round. Beyond that, we hope to be able to integrate it with e-prescribing, which is a massive task, and also for provision of discharge summaries. That communication with referring doctors and general practitioners is absolutely essential, and something that most hospitals don't do well. I think all of us who've come up through the system can remember as a resident sitting down towards the end of our term, confronted by a room full of undictated discharge summaries and sending out information to doctors 6, 8, 10 weeks after the patient had been discharged or died, and clearly that's unsatisfactory. I'd like to think we're better than that now, but we're only a bit better. But when you look at it, PAS already has much of the information that the referring doctor needs, as who the patient is, when they came in, what their diagnosis was, when they went to theatre, who was looking after them, the date of discharge, and the laboratory investigations now. So it won't take, I believe, much more work to develop a template that populates most of a discharge summary. PAS also has a database that has the information that has a database with our general practitioners' contact details, their preferred method of contact, and I could foresee that as the doctor discharged the patient from their iPad, that almost instantaneously the GP could be receiving either an encrypted email or a fax informing them that their patient was going home and what had happened to them during their stay. So that's the vision at the moment. In the future, beyond that, I think if we've got our doctors to the point where they're doing all of that electronically, I think they'll come and say to us, well, why are we still writing in the histories? And then we'll provide a solution for that. That's my hope anyway.